So we're going to be talking about temporomandibular disorders. So what gives anybody credibility to talk about anything in dentistry? Because we all have the same doctorate degree. There isn't an advanced degree that you get in temporomandibular disorders. You have to show an interest in it and study it and work at it a long time. I think I have a particular insight into parafunction just because I was a sufferer for so long and dedicated my career, ultimately, into managing parafunction. Ultimately, we'll be talking about the when and why of the NTI. And NTI is a mechanism, or it's a protocol to manage parafunction. There's a continuum of parafunction, which we're going to talk about. So the NTI is not indicated for everything. That's the whole goal of this course, so that you can observe and diagnose a patient and determine what's the best treatment for them. Because you went to the NTI lecture and Jim Boyd said, well, you don't always use an NTI. He said that? Well, when don't you? And when do you, when you use it, how do you not mess it up? As Barry Glassman and I did this for years together, we kept talking about the TMD Vinci code, because dentistry keeps using terminology that us at a dental school just, oh yeah, okay, because that posterior interferences causes muscle hyperactivity. I'm going to talk about that specifically. That is pure TMD Vinci code, because no one knows what that really means or what they're really implying. So I'm going to go through, we'll hit a lot of those today. Like temporomandibular disorders, that's the first one. Is there something wrong with someone's temporal bone, their temporalis muscle, their mandible? What specifically does that mean? Better stated, we're going to look at trigeminally mediated disorders. Everything that we look at in this particular field is mediated by that trigeminal nerve. We just haven't been paying very close attention of the capacity that this nerve has and the impact and influence it has on our patients. Our typical daily relationship with the trigeminal nerve in general dentistry is to try to conceal from the sensory nucleus what we're doing out there. You're not going to sink a burr into someone's pulp canal unless you've totally blocked sensory information to the sensory nucleus. So you get those things completely anesthetized. Can you imagine if you could strap somebody down, drop a burr into their pulp canal, have them scream like crazy, but they can't move because you got them strapped down? Man, that hurts. When you take that burr out, it still hurts. Later on that day, it'll ache like crazy. You have had an assault on the trigeminal sensory nucleus. But if you had anesthetized them ahead of time, the sensory nucleus doesn't even know what's going on out there. So without profound anesthesia, if someone's hurting during your procedure, they tend to be achy and headachy later that day. This lecture isn't going to talk about migraine prevention, but what I just touched on is a noxious assault on the trigeminal sensory nucleus. Neurology has been searching for a way to relieve the sensory nucleus from getting noxious input on a regular basis. They think if they could figure that out, they could reduce migraine frequency. And NTI does that. Clenching provides to crushing the PDLs, muscle hyperactivity, et cetera, joint strain, which relieves noxious input to the sensory nucleus. There's my NTI migraine lecture for today. So now we're trying to, in dentistry's relationship with the trigeminal sensory nerve is to block any information to the nucleus. So once you've blocked all this, take a look at this Gray's diagram when it talks about the motor route. That's all you really get to see. No one really talks about motor intervention to the muscles of elevation. A little review on our muscle physiology. Muscle force, how much force does this muscle generate when it begins to contract? It's controlled by the neuron action potential recruitment, meaning how many fibers are innervated within that muscle. The recruitment follows the size principle. The more fibers that are innervated, the more force that will be created. So the more fibers that are innervated, the larger the motor unit becomes and the more force that is generated. They used to rate light in candles or lumens, foot candles. One candle, it's either the candle's lit or it's not. If all of the candles lit, you get a lot of light. the percentage of fibers that are contracting dictates how much force is being generated. Here's observing the gastrocnemius of a cat and how the muscle system works. And we're going to look at, this is going to be a muscle here that's going to represent the fibers that illuminate here that are being innervated. So to stand quietly, 25% of the motor neurons in a cat's leg are innervated. It's just standing there quietly. It doesn't need any more than that. To run, 20% of the force is generated with half the fibers being innervated. To jump, almost all the fibers are innervated. That's as much force they can put. Boing, up they go. When we're walking, I'm 200 pounds. My legs, as I walk forward, aren't trying to propel me faster than a walking speed. If I wanted to run, I have to use more muscle force. You probably thought there was going to be a step in front of you, and if I thought there was a step in front of me, I have to get more than 200 pounds of force to elevate myself any higher than the floor. When you think there's a step there and you go, boom, oh, sorry, I thought there was a step there. Your leg was anticipating more than 200 pounds of force necessary to elevate you. So your muscle worked much harder than it needed to. The purposeful necessity will dictate the degree of muscle innervation. What you need to have done is how much muscle fibers that will be innervated. So here's the motor root, and we're going to innervate the temporalis muscle, and here's an EMG device monitoring the amount of electricity that's underneath these electrodes. And I like to call the teeth these circuit completion devices. We're going to complete the circuit that we're going to, in order to allow innervation of the temporalis muscle. When the incisors are contacting, only enough innervation is allowed for about 30% of maximum force. You can't get more than that. If you only have incisal contact, you can only get about 30% of force generated. If the canines are contacting, you can get about 75% of the force because more fibers are being innervated. The maximum force that can be generated is when the molars are in contact. When we talk about the rules of parafunctional control, and there's only 2 of them, the first one is to minimize the intensity of muscle contraction. The way you minimize muscle contraction intensity is you eliminate the ability to innervate the fibers. The minimum amount of fiber intervention happens when there's incisor contact. So now let's take a look at a little different perspective here. If you've got someone with their mandible at rest, and you ask them to raise their mandible a little bit, and you've got them on an EMG, you're going to watch as the electricity underneath these electrodes is increasing as they elevate their mandible. And Barry has a great video of that with the patient. He's got them wired up and goes, close your mouth a little bit more, a little bit more, and you'll see as they start to elevate their mandible, although there are more fibers contracting, you won't see anything on the EMG. It's not even enough to show on a device that's looking for a reading. It's not even there yet. You can get someone to actually get their teeth to touch and not get much increase. So you have to ask them, all right, look, I want you to start clenching as hard as you can. We'll call that maximum clenching voltage. That's even in the literature, MCV. So this electrode is now seeing underneath it the percentage of fibers underneath it that are actually being innervated. And and in this particular example, there's a degree of microvoltage that we'll see on this. If you put a full covered splint, everything's touching all at the same time, and you say, ready, clench as hard as you can, they'll be able to generate more voltage. It's even a more forceful contraction. You know why I think that is? I think there's purpose in having something between your teeth. When your teeth are together, what are you doing? What's the design in that? Why is that purposeful? Why should that be the most powerful, forceful thing you can do if your teeth are together? What does it do for you? You need to have something in between your teeth. That's what they're designed to do. So true maximum clenching voltage is with the teeth slightly apart. Something's in there allowing them to communicate. If you remove the anterior segment, it's just all molars, you still get maximum clenching voltage, the most fibers that you can innervate. Now, as I move this back and forth, the condyle, the mandible, there's no positional change at all. The only thing that's going to change here is the circuitry completion. We're going to unplug these molars. They're not going to touch each other. We're going to plug in the incisors instead. Nothing else moves. And you still ask the patient, still squeeze as hard as you, this is as hard as you can, right? Nothing else will change, but you'll have a drop in intensity. So all of these skeletal muscles are at rest right now. And we're going to ask some muscles to contract. So most would say, okay, I see what you got. You got the deltoid is contracting to raise that arm. You may not have noticed that there was a space between the teeth in the original image. And so right now, this skeleton is contracting temporalis muscle because these teeth are touching up here. Everything I could ever find on the internet, everywhere, teeth are always touching each other, always occluding. There's always occlusion going on. You look up a picture of the temporalis and you see that it must be contracting because these teeth are occluding. I had to digitally alter this just to put a space here to show that what normal rest position would look like. But in dentistry, you kind of go, that's just kind of weird looking. We don't grow up in dental school seeing that. If you look up the medial pterygoid and the lateral pterygoid, you'll get this image. Do you think that the illustrator was tasked to showing contracting medial pterygoid and a contracting superior head of the lateral pterygoid? Because that's what we got. For those teeth to be occluding, that medial pterygoid has to be contracting. During elevation, the superior head of this lateral pterygoid contracts. So that's what, when I see these now, I'm looking for things. I'm looking for what's going on in this still shot of an activity. And this is an activity right here, but we in dentistry don't see that yet. We still look at, that's a nice class 1 occlusion. That's going to be our biggest TMD Vinci Code term. This comes from a textbook. So if you were to take out the words that don't mean anything right now, this tells us, and we all grew up reading these textbooks and assuming that's got to be true, but you're not kind of sure why it's true. It seems weird. A posterior interference effect is hyperactivity of all of the elevator muscles. A posterior interference, its effect is hyperactivity of the elevator muscles. So there is a posterior interference, a contact. And we're learning that we were told that at that contact, this thing, this item, as if it's an actual object, can cause the elevators to be hyperactive. No way. Never, never, never. It does not happen that way. What really happens? To have so right now, these teeth aren't touching. During sleep, typically, if there are hyperactive elevators, that causes occluding. That's the only way teeth can occlude. You have to have an elevator that contracts and stays contracting. Otherwise, the contact stops. So hyperactive elevators will cause occluding. The occluding scheme will govern the percent recruitment of elevator fibers. So if you have hyperactive elevators, the scheme of occluding teeth, in this example it's going to be these molars, will allow for near maximal contraction. It's not causing maximal contraction, it allows for it. If you were to put an anterior jig that did not allow posterior occluding, you still have constant elevation, but the new occluding scheme now governs the degree of muscle contraction or the number of fibers contracting. So where this was a big, huge force vector arrow, it's much smaller now. Nothing's changed in the position of the mandible or anything like that. It's the occluding scheme that's now governed the amount of muscle contraction intensity. A better term is trigeminal motor innervation to the elevators. I like to keep bringing back to what this trigeminal nerve is doing, because when you think about migraine and you talk in those terms to the neurologist, they think you know what you're talking about. You might not, but it sounds better. So this term, the occlusion, to me that is an activity. It's not a thing. You can't hold an occlusion anywhere. It is the result of contracting, elevating musculature. So I don't say the occlusion anymore. I call it the occluding scheme, and the occluding scheme changes all the time. Occlusions happen on articulators when you look at them. Occluding schemes are things that happen to real people that can change from minute to minute. And the report that they give you and the signs that you see tell you how this occluding scheme might be affecting that patient. This whole business about the hyperactivity of a lateral pterygoid, as if that has been our opponent. This intense lateral pterygoid activity, this hyperactivity, it's just trying to do its job. Let's take a look at what that thing is really trying to do this whole time. So there would be a temporalis muscle, and as you see that there's occluding teeth, you go, wait a minute, that thing shouldn't be dark like that. It really is an activity. I still see occluding teeth as an activity of the musculature. It's easy to determine and to see and to watch and to measure maximum contraction of a temporalis muscle. Oh, by the way, I want to address this real quickly. I look at some of the images I make. Some of these are 12 or 15 years ago, maybe even longer. And I wish I had drawn all these little lines appropriately in their right orientation, because a muscle can only get shorter, and the direction of that fiber dictates where the attachment is going to get pulled to. So this is inaccurate. Most of these fibers go this way. The anterior temporalis resides in a very deep depression in the anterior fossa here. It's a really thick, meaty muscle. We don't know that. You can bounce back here to the posterior temporalis, which is kind of thin. And you know what a posterior temporalis can do? Get shorter. That's all a muscle can do. And a posterior temporalis attaches to the coronoid process. And why would you need a muscle that pulls a coronoid backwards? After you protrude, how do you retrude? Posterior temporalis. Well, so, okay. Most of the temporalis, the real action is in the anterior segment. So let's talk about the lateral pterygoid. If it were to contract at maximum, the elevators would have to allow it to do so. And I don't really think we ever see anyone with a problem of hyperactivity of the lateral pterygoid, because they'd have their mouth chin forward all the time, or with their digastric, they'd be open all the time. There is no such thing as a, all by itself, hyperactive lateral pterygoid. So how can I demonstrate, how can a lateral pterygoid get fatigued? What's really fun is, you guys can't see yourselves, but I can. It's fun to watch people going, practicing. There's the hyperactive lateral pterygoid, if you want to call it that way. How can I fatigue that muscle? I need to provide resistance. Anyone who wants to work out a muscle needs resistance. How can I resist that advancement and opening of the mandible? I can hold it closed, and that lateral pterygoid is still contracting in there. Here's the one time I've got occluding that's not the fault of the elevator. It's this clamp that's holding this jaw shut. Now this lateral pterygoid is working really, really hard. And we're used to seeing teeth together all the time. We stipulate they're together all the time. we stipulate the occlusion. And Barry Glassman would talk on the internet about, well, you're stipulating the occlusion. I go, what are you talking about? That sounds so weird to say. But we know what we're thinking. It's the occluding is what is happening all the time that we have stipulated. We call it the occlusion. We seem to start from that position. But still, I keep talking about a resistance to reopening. With this lateral pterygoid, it's a resistance to reopening. And I can remember Barry Glassman saying to me, look, Jim, just because dentistry starts or stipulates at closed, that's what we think about. Resistance to reopening, my Jim Boydian term, doesn't make sense. I understood what I was talking about. Barry got it. He goes, no, they don't get what you mean. Resistance to reopening? You need a term that they understand. How about resistance to movement? I thought about that. Why did that word make sense in dentistry? Because we call them functional movements. Quick, what's a functional movement? Protrusive, excursive. When's it? During mastication? No. After you're closed and you move sideways and you rub your teeth together, that's an excursive movement in dentistry. We call it a functional movement. There's no function there. There's no purpose. I like to take the word function and forget it. I like to call it purposeful. What are the purposeful movements of mastication? Any monkey knows that. We don't care. No one seems to be missing meals in our field. What are they doing when their teeth are together? They're parafunctional movements. And there's resistance to movement, and the resistance is felt by the lateral pterygoid that's trying to move or open or disclude these teeth. Here's an example that I just tried this past week. It's how to show yourself what a fatigued, sore lateral pterygoid must feel like to your patient. If you open your jaw slightly, keep your teeth apart, and do not let your jaw move at all, and rest your fist against your jaw, and press your fist against your jaw, but do not let your jaw move at all, the opposite lateral pterygoid will resist you and hold your jaw from being pushed off to the side. Push a little bit harder, and your lateral pterygoid is now going to strain and work a little bit harder. If you push really hard, you will get the strangest sensation and pressure under your eye. And I've done it, and I get a headache for about a half an hour after. I hate doing it. When you're by yourself, open your jaw a little bit and push like crazy as hard as you can. And you almost will resist pushing because the feeling is so strange. That is the resistance to the lateral pterygoid. Now, normally, the contracting lateral pterygoid would advance that mandible, and there isn't resistance at all. It's an easy thing to do. Opening your jaw or protruding your mandible is not hard to do. There's never any resistance there for it. Here is a purposeless unilateral movement. There are no teeth occluding in this example. And so this lateral pterygoid, when it contracts independently, not all of the fibers are needed to contract. I only have 4 lines there, so I made 2 of them sort of light up. Here's a unresisted attempt by the lateral pterygoid to advance its condyle. Now, if we want to create a point of contact, a contact isn't a thing, it's the result of an activity. So here's a temporalis that's contracting and elevating the mandible, causing a contact that we're now representing over here. So that contact is the function of the contracting temporalis. As the lateral pterygoid now begins to contract, it encounters the resistance. If it increases its contracting, it could break that contact. Sort of like what grinding is all about, as you break contacts and move these teeth across each other. So here's a lateral pterygoid encountering resistance and then moving the mandible from these occluding teeth. So the degree of the occluding resistance, it's a function of the clenching intensity. And that dictates how intense the lateral pterygoid is contracting. There isn't any food that wears out a lateral pterygoid. That's for the elevators. This is unoccluding the teeth if someone keeps occluding them. Let's increase the degree of contraction of the elevator and make that a stronger, heavier, I don't want to say heavier, it's like a bigger piece of blue paper. It's just a more intense holding together of these teeth. We're going to intensify the degree of contact. So now when this lateral pterygoid contracts, it can't break that contact apart. It's met with a static resistance. It can't move the mandible at all. Because this mandible is sort of a horseshoe shape, it now allows a little bit of contortion to happen in the mandible. And the force vector is always at the point of resistance. So now you have a cross the arch, medially directed force at that most distal contact. That is a fantastic way to wipe out a joint. So when we talk about, well, you don't want a unilateral distal interference, that would be really bad. Well, why? Here's why we don't like these unilateral distal interferences. It's the opposite side condyle that can get strained. And in dentistry, we even have an adorable term for this. It is one of the TMD Da Vinci Code stellar. As if it's a good thing, we call that posterior support for the joint. Do you have posterior support for the joint? What does that mean? If you really thought about how you support a joint, that with gravity is relaxed anyway. What are you trying to support? We think about, do you have support for your knee because you twisted it skiing? What kind of splint do you have on your knee? So we think about splints and joint support and all that kind of stuff. We call that posterior support for the joint, because if this lateral pterygoid tried to contract, nothing will happen. This condyle cannot be pulled medially because of this contact here, which I like this better term, posterior immobilization of the joint. I like that. Sometimes you don't want that condyle moving, you want strain. Well, if they're going to be closing, at least we can immobilize the joint. Let's borrow the elevator muscle in the posterior segment to immobilize that joint. It's not posterior support, that sounds like a good thing. This is posterior immobilization. I think that's the more accurate term. What if we move that contact to the incisors? So now this little dot here is much lighter because there's only 30% degree of elevator contraction intensity. And to move the mandible across an incisal contact doesn't take much more effort anymore. It's easier to do. There isn't as much resistance. You can't provide enough resistance to render this lateral pterygoid helpless. It will still move it. Because incisal contact only allows 30% maximum of elevator contraction intensity. And when you start making some NTIs someday, you'll go, look at that divot. Did a posterior contact cause hyperactivity of the elevators? There is no posterior contact. These people are still occluding. They're still closing. They're still moving side to side. They'll wear a divot into a discluding element, but at least they can move. That's an upper discluding element. Here's a lower NTI device, and this is where two centrals have moved side to side. Could you imagine putting a piece of plastic in your mouth and only having your centrals scrape into plastic? You couldn't do that during the day to save your life. It's so creepy and weird and hard to do. People wake up and like, wow! I look at stuff like that and I try to imagine what it takes to make the kind of markings that people do in these devices, and it just boggles my mind. It's amazing. So usually dentistry likes to talk about the canine because that's so important to us because we need canine rise. Not for chewing food, obviously. It's another thing you used in parafunctional control. Canines, basically the size of that canine, they're designed to bite and squeeze into things. They're for clenching. Animals that have big canine teeth survive by clenching into things as long as it takes till your dinner is dead. Herbivores don't have big canine teeth. They don't need to bite into that piece of grass that long. They need to mill it around. So herbivores have big masseters and big arcade of molars. You got to hang on to those things. So what about the masseter? Well, because we used to focus on it so often. I don't care about the masseter. If I can defeat the temporalis, I'm good. Here's a study. We're going to have someone clench their teeth together. As time goes by, their masseter's getting sore and tired. Keep on. No, you can't stop. Keep on. My masseter. How's your masseter feel now? Doesn't feel so bad. Really? It's because it gave up. It's short acting. It's for quick bursts. It's for sprinting. You want a long-term miler? You want a long-term intensity? Temporalis just keeps on going. It doesn't care. Because they help you survive. A temporalis is designed to clench into whatever you need to eat until it's dead. It'll take you as long as you need. So now we're looking at a little bit of basics and some terminology. Now we'll get to diagnosis of what the patient is presenting you with. It's the nature and the cause of a disease or injury. And dentistry is fantastic at describing the nature, especially in temporomandibular disorders. We're very, very good at describing the nature of the disc displacement, whether or not it reduces the degree of pain that the patient is in. We're not going to talk about normal anatomy and normal physiology. Something abnormal is going on that we're going to describe. So the patient's presentation is going to have abnormal anatomy and or pathophysiology. The nature of the diagnosis in our world are anatomic deviations, that'll be the signs, subjective reports like the symptoms, joint derangements, muscle conditions, occlusal classifications, types of pain. So we're reading Dental Town posts and saying, well, what's your diagnosis? This diagnosis is anterior placed disc with reduction and pain. What's your treatment? They start treating the signs that they just described. Well, I got that. I got anterior disc displacement with reduction. You're going to treat me? Well, yeah, you're going to die someday of that. Well, it's been 30 years, not yet. The other half of diagnosis is the cause. How something got that way, or how something is staying that way. So when I got hit by a basketball in my jaw when I was a junior in high school, and I ran down the car, I was like, what the hell going on? I couldn't call him out. You can't treat that anymore. That was a long time ago. I got a click now. I have parafunctional control all the time. So how it got that way is long since past. But if I'm going to clench every night and go to the side and squeeze, that's how it stays that way if I'm symptomatic. So we've got to know both things. What the patient has become, their complaints, how it got that way, and how it stays that way. If you can imagine how it got that way or how it's staying that way. Like when you see plastic with grooves in it, can you imagine if they didn't have the plastic in there? That's how it gets that way. But we don't extrapolate that. That's what we really need to be doing. So as we swirl around the cause of these signs and symptoms, there's a whole bunch of schools of thought. We're going to start with purposeful function. We need to grasp, tear, crush, chew food. That's what we need to do. That will obligate the forms that we need to do what we need to do. So purposeful function obligates these necessary forms, these shapes of these teeth. Function obligates form. The forms that we have, these molars and canines and incisors, that allows us to do things we don't need to do. Purposeless activities. We don't need to do it. I shouldn't even say function there. Just because we have them, we can do weird things. It's not okay. If you do, and here's a fantastic, I moved out of the camera. Bruxism is going to be a terrific term to look at in a few minutes about part of the TMD Vinci Code. Purposeless function will dictate altered forms. Teeth are getting worn, joints are being the signs of the joint are sometimes not symptomatic. Signs in the joint and the disc, we start to see altered forms. And those altered forms will now modify how someone is functioning. Their teeth are worn down, their joints are strained, they have to chew differently, so their function has been modified. So this swirls around the patient's signs and symptoms. Do worn out teeth and a displaced disc cause someone pain and misery? Not all the time. You can have a ton of people like that. Guys, their teeth are worn flat, they feel fabulous. What if someone says, well, I think your function is improper. I put you on the Dealey Bob and your closure is too fast. You're functioning improperly, so you're getting fatigued. That happens out there. I don't think that's it. You don't have the necessary forms. You're not in a proper class 1 occluding scheme. I think that's your problem. I had to change that. What if you got this pathophysiology? I think that's where it is, because we can't imagine it. We don't think, oh, that would be weird if they did that. Hello? That would be weird if they did that? That's the diagnosis. That's weird. That's where we need to focus. So this TMD Vinci code of bruxism, we take that way too casually. Bruxism, clenching and grinding your teeth. I mean, in the neurology clinic, they used to think of bruxism like, who cares? What? Yeah, so you put a thing in their mouth, they grind on it. What are you talking about? No, you guys, it's way different than that. What does someone need to do to experience bruxism? Do they need hyperactive lateral pterygoids so their jaw waves side to side or forward and back? If there's no elevation happening, who cares about hyperactive lateral pterygoids? It's just silly. So we've got a little bit of side to side and hardly any elevation. Let's add a little bit of elevation to this lateral pterygoids that are not doing anything anyway. If you have a little bit of elevation, just so the teeth can be approximated somewhat, you've got grinding of the teeth. There's the person who they didn't feel bad. Wow, look at your teeth. Don't you feel awful? No, what are you talking about? If you increase the elevation still further, the lateral pterygoid now has more resistance in its attempt to move this mandible. Sometimes you'll get force vectors going, and sometimes the position of the occluding scheme creates force vectors that damage the joint, or crush the tooth in its socket, or shear off a cusp, or strain the muscle, so you get muscle aches and headache and jaw. Excursive clenching, I think, is part of bruxism. Let's just have them elevate their jaw as intensely as they can. I don't care what the lateral pterygoid does. That jaw's not going anywhere. I call that primary clenching. Clench like nobody's business. And you know what? The teeth look fabulous. There is no dental wear in a primary clencher. And their jaw joints are both stable because they have posterior support for the joint on both sides. That is immobilized joints. That person can be ridiculously miserable with headache and migraine. To me, the definition of bruxism is jaw clenching, with or without forcible excursive movement. I don't think grinding, I think clenching. The intensity of the clenching will dictate the severity of the signs and symptoms. If you have minor, minimal clenching, it's not going to be a problem. So these things present kind of uniquely, but they blend into each other. Grinding can be asymptomatic. Super common in the population. There's considerable tooth wear, and there's a high demand for low-cost therapy. The Doctor's Night Guard, or whatever it is at Rite Aid Pharmacy, there's a whole bunch of those things in there now. Excursive clenching, you could have some pretty interesting complex symptoms, the TMJ disorder patients. It's moderately common in the general population. Unusual tooth wear patterns, really weird. You have to look for them sometimes. And there's a cautious demand for moderate therapy. Every time I see that, I remember my wife was my first NTI patient. I didn't know she was going to be my NTI patient, but as a new patient, her jaw was aching. She had these headaches. She goes, yeah, my physician says I should probably see a TMJ guy, but I know you guys are just in it for the money. The TMJ industry didn't have a very good reputation. There's cautious demand. You better watch out. It might not work for you. It might backfire. Why? I don't think we understand what's going on, how it got that way or how it stays that way. In clenching, they could be severely symptomatic. It's highly common in the population. There's unremarkable tooth wear patterns. There's a high demand for effective treatment. But we don't even know what's out there. Teeth look fine, raging headaches, jaw joints are fine. Why would we even know this is a patient that we can help? They're over in the neurology clinic. Oh God, raging headache, blah, blah, blah. Go like this. Did your jaw click? Did your jaw click? Do you grind your teeth? Oh, don't go see my TMD guy. That's what the neurologist would say. Our treatment is diagnostically driven. Each one of these patients can be treated differently or should be. So an insight of purposeless function is going to require an understanding of purposeful function to see what really is supposed to be happening when it's happening. So we can back out of it and say, you know, that other stuff that's kind of weird. We need to address that. Let's take a look at normal. This guy's in rest position. He closes. We've got the medial pole at its highest position. We'll call that CR, centric relation. I didn't put any muscles on this diagram. That should look weird. Like, how the heck did he get that jaw to elevate like that? So I always imagine there's a muscle in there occluding. This is an occluding scheme right now. And our occluding scheme is allowing for providing where the condyle is at its most superior position in that fossa. We're going to call it CR. But I don't want that arrow in my way for now. This joint it's really two joints. There's the superior side of this disc that articulates against the eminence. There's the superior side of that joint. And this inferior side was the condyle and the inferior side of the disc. There's two separate joints there. They both do completely different things. If we wanted pure translation, where the lateral pterygoid is contracting all by itself, if you start with the condyle at its highest spot up that eminence, braced in that centered position at CR, and all you wanted was lateral pterygoid contraction activity, the condyle comes down out of CR and all of the teeth will disclude. That's just the nature of the slope of the eminence. And that's really why we use CR. We're trying to disclude teeth in the event someone slows down on their clenching intensity. Had nothing to do with mastication. CR, when they say CR in our functional occlusion, no, we're using CR to address parafunctional occluding. Because once someone's up in CR, we need to get the posterior teeth discluded as soon as we can. We saw how bad it is if you have a unilateral posterior contact. The posterior contacts allow the most muscle contraction intensity. If they're going to be occluding, I hope it's not the posteriors that are doing so. Coming down out of CR is the first line of defense in traditional occlusal therapy to disclude molars. So when someone says, when you try to seat someone to CR, you find the interference to CR. The condyle can't get to CR because there's a palatal cusp banging on a distal buccal cusp of a lower molar before you can get to CR. We're trying to find those things because that same interference to CR is the first contact coming down out of CR. They lean on that one posterior contact and you have joint strain on the other side. So Pete Dawson, who I adore, says, look, we need to get them to CR first, and then when they're coming down out of CR, you can't get joint pain because there's no posterior interference, no posterior contacts. We'll show that in a second. Let's look at the positional range of purposeful masticatory function. So the translation side of this disc is commensurate with the anterior-posterior position of the incisors. We're going to incise on something here. The inferior side has to do with rotation. The rotation of the condyle is commensurate with how the vertical dimension of the bolus that you're about to engage. How far forward do you have to go? How far open do you have to go? So this degree of translation from that red arrow to here is represented. The black arrow is this black line. That's how far translated the condyle needed to go to get incisor over incisor for incisor. You don't need to go farther than that. So we put a bolus in here. The vertical dimension of the bolus dictates how much rotation of the condyle needed to occur to accommodate for this bolus. Now, is this bolus going to be a frozen grape or a regular grape? With incisal edge contact, we're only going to get 30% of maximum clenching voltage. So that's kind of okay. Hey, that's in that incisal contact. However, even with 30% contraction, if the condyle is overly rotated, When there's incisal edge contact, you get joint pain. Nobody bites on something hard with their teeth that far apart. We all know it. It needs to get a little bit smaller before your teeth can bite it. It hurts up here. That's how the system works. Overly rotated condyle, too much vertical dimension of the bolus will cause joint strain during the occluding act, even though you're only at 30% of maximum. If you could just make that thing smaller, you're okay. You'll get 30%. So the number 2 most common reason why an NTI fails, they're too big. Too much vertical dimension of occluding. You've over-rotated the condyle during a closing event on the object. So as you go through, I made this GIF a while back for a purposeful function, but the farther back the bolus gets, the closer the molars are getting and the more compression, the more crushing that the system is capable of. And as the intensity increases, it's only when the bolus is at its farthest back position and the joint is the least translated and the least rotated. So normal crushing of food, when it gets to your back molars, their molars aren't very far apart. When you go to crush the most, the joint is the most seated and braced. The opposite, if you provide something that allows them to clench with their condyle overly translated or worse, overly rotated, you're going to get problems. You're not going to understand why this patient doesn't feel better. Why does it hurt? I made a splint. Why does it still hurt? It could be the dimension of your splint, or it could be where they go on the splint. So now we'll look at the positional range of purposeless masticatory function. Let's say we want our patient to go into a protrusive movement. Now, usually protrusive, the lateral pterygoid provides translation. Is that what we're going to get? But if we say, I want to see your patient in protrusive movement, show me right now, Dr. Boyd, on your articulator or on your patient. The patient will protrude and we have their incisal edges still touching. That's called protrusion. As a functional movement. That doesn't happen in mastication. What are you doing? What purpose does that serve? But it's a parafunctional move that happens when people are asleep sometimes. We've just flip-flopped some of the terminology, so we don't look for that. We don't assume that could be pathologic because we called it functional movement. So in protrusion, if a protrusive resistance sometimes ends up, these incisors are still engaged. What does someone's teeth look like that has a protrusive resistance component of their parafunction? The terminology of constricted envelope of function is completely misleading because nobody chews like that. They'll say he chews like a rabbit. So you get the image of how these teeth are worn, but that's not how real function works. Real parafunction doesn't work like that. There is no constricted envelope of function. It's a parafunctional act. Parafunctional protrusive resistance is what's happening. It gets that look of the teeth that this chews like a rabbit gives. But unless you think of this, you really won't be on top of how to treat the patient. Otherwise, you're trying to treat how they chew food as opposed to how they're parafunctioning. So if someone didn't have any incisal overlap at all, sometimes that creates a natural barrier in the patient's teeth. Their condition tends to go there. And these protrusive parafunctioners. What if there was no incisal overlap at all, like a class 3 patient, incisal edge-to-edge patient, a flat plane splint patient that wasn't a flat plane splint patient a week ago, but you just gave them one. And here is the purposeful condylar position, edge-to-edge. There's no reason to go beyond that. Parafunction doesn't care. It's out to make you look bad. It will do to that patient whatever it needs to do to make the patient hurt and to make you look like an idiot because you can't figure it out. In protrusion like this, you can get posterior contact, you get joint strain. It's terrible. And interestingly, when someone protrudes, their ability to contract the elevator starts to go down. It's a little less efficient. I haven't done all the reading on that yet, but you'll find that I think that's one of the cool things about apnea devices. As they open and are more protruded, the elevators are not as intense as they could be. So we'll put a flat plane splint in there. And patients can go flying right off the end of that. And if you don't ask them to do that, you wouldn't know that they do it because they didn't have to before. If they have a degree of incisal overlap and they go forward and they're pressing on their canines or something like that, and they're symptomatic, you give them a completely flat plane splint, and they do okay for a few days, and all of a sudden they get this weird stiff and sore neck, and they're hurting behind their eyes. You go, what is the deal? Have them go forward as far as they can. And when they squeeze the splint, they'll go, oh, that's weird. I know I don't do that. Why do you know that? Because that doesn't feel good. I'll bet you that's what you're doing. We'll say, well, you've got hypermobile joints. You weren't hypermobile before you put the splint in. The muscular activity is causing this to be hypermobile. So the presence of a splint, which is a new occluding scheme, can allow for new parafunctional positions. So when you put a splint in someone's mouth and their condition changes, they're doing something new that they couldn't do before, but now that they can. I always imagine that the patient's condition is trying to make me look bad. And when the patient tells me, well, I think that maybe if you could just make this a little thicker, or that, and I say, you know, your condition just told you, tell him to make it thicker, because that will really make you feel worse, and he'll probably do it. Because you want to do whatever the patient says, because they're not feeling good now, and you want them to like you, and want them to do the right thing. I say, you know what your condition just told me to do? Oh man, if I do that, we're in trouble. Oh, okay. So you just made them a splint. And you said, well, this person, I think they're going protrude. They're going way out there. How can I modify the occluding scheme to manage this? First thing I need to do is rule number one, minimize muscle contraction intensity. I need incisal edge contact. How do I do it? Well, I can make it a big, huge extension on this thing. Well, that'll work. But it just looks kind of dumb because they got this plate sticking out of their mouth for these intense protruders. And I made them that way. That's the working part right there. We need to get incisal edge contact. Perhaps we don't have to stick with a maxillary splint. If you made something on the mandible, that might look and work better. You'll get incisal edge contact in protrusive. There's rule number one accomplished, minimize muscle contraction intensity. So we're sort of getting into splint design now. Let's look at what is causing that activity. And it's this parafunction and these occluding schemes that occur that allows these signs and symptoms to happen. Here's primary clenching. That person wouldn't have any wear facets, perhaps. They may not complain to you about any facial pain or joint pain. They might wake up with a headache all the time and never tell you about it. Here's contralateral joint strain. We call this the working side, as if someone's chewing food right now. It just means the condyles translate on the opposite side, so we call it the working side over here, as if that's where you would be chewing food, because this side is translated. This is during a closure event, but we still use that term working as if it's a normal thing. If the contact on the same mandible, they're all in the same excursive position, but the contact has just changed its position. Here's a posterior contact below the translated condyle. That's a great way to crush a disc. Canine resistance, which we love, we use the canine as the patient is opening and the canines are rising up on each other. That's great. Opening, I love an opening movement. It's when they start to reverse field, go the other way. Sometimes they'll go all the way up and they'll go canine to canine and they'll squeeze like crazy. There's a new occluding resistance. Sometimes you have canine resistance. The canine tips are flat. Or protrusive resistance. I call these protrusive clenchers. Sometimes they'll go right past the incisal, they'll flip-flop. So you treat them with a splint. Here's a lower flat plane splint with canine rise. If you were to provide that splint, they could still clench like crazy. You probably wouldn't make that for a primary clencher with a complaint of headache and nothing else. You probably wouldn't even know they were a patient to be treated. But in excursive movement here, so we got a little canine rise, and now we instant posterior disc-gluding. Now we don't have joint strain. Pretty good splint for someone who has a joint problem, because the joint strain and problem comes from the occluding schemes that we've just eliminated. Because back when they were centrically clenching, we had posterior support for the joint, or constriction or resistance. We wouldn't let it move. We still have canine through canine clenching on one side, 70% of maximum, so you could still have a headache patient. That might not change them at all. If you go back to center and slide forward, here we have incisal edge contact on that splint, and so you eliminate this protrusive resistance. So we still have some things that are still left over and why this splint didn't help that particular presentation. It's back to this canine problem right there. Pete Dawson said in his textbook a while back, after occlusal treatment of any kind, I ask the patient to close and clench as hard as they can. Okay, he's got that out of the way. Can he clench? Does it hurt? No. I ask them to grit their teeth and grind in all directions. Why? He wants to know if there's going to be a posterior contact in an excursive movement, because if they can elicit any sign of discomfort, I know I'm not finished, because when I have complete harmony with CR means there are no interferences going into and out of CR posteriorly. That's what he means by harmony. It's impossible for the patient to feel discomfort in the joint. That's where dentistry lives. We're trying to make, look, you got no joint pain. Ta-da! Clench on your splint, clench on your occlusion, grind to the side. Are there posterior contacts? Because if there's not a way to strain your joint. So that's what he's looking for. Interestingly, now in his latest textbook, he talks about the NTI. What we did not realize in past splint fabrication is that canine contact does, in fact, permit an increase in muscle contraction activity over a single midline point stop. The difference is significant enough to warrant its use in diagnosis as well as for clenching suppression in selected patients who continue to clench even with a perfected occlusion. We're still convinced if the occlusion was just perfect, why would you clench? Because a long time ago on that slide it said a posterior interference would cause muscle hyperactivity. We think that posterior contacts were causing muscle hyperactivity. If you have a perfect splint, there's no interferences, therefore you won't clench intensely. It's not true. So the selected clench even with a perfective occlusion. So now, Dr. Dawson, you know what? Some people have perfect occlusion, they clench anyway. It might not be because of the occluding scheme. So what are our goals in splint design? We want to have decreased joint strain. We want to protect the teeth. We want relaxed muscle. Sometimes I'll see in textbooks a full covered splint. They call it a muscle relaxation splint. It doesn't mean anything. It's a less contracted muscle splint than before. That's your goal. But a full covered splint may not guarantee that. In excursive movements, if you get posterior discluding, you'll get decreased muscle contraction. So an anterior midpoint stop will create less intense muscle contraction, and our therapeutic goal is to exploit the efficacy of this concept. Muscle deprogrammer, Lucia-Jig, Pankey device, that's the beginning, but nobody sits there and goes tap, tap, tap on your deprogrammer when they're asleep. You go tap, tap, tap on your articulator, you put it into a tap, 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 seat your condyle, take your impression. Parafunction doesn't work that way. It will do whatever it takes to get around whatever you put in there to make you look bad. So here is the typical Pankey deprogrammer. This will reduce muscle contraction intensity to 30%. That's where we're going to start from. How can it go wrong? That's what I was thinking. What can go wrong here? Let's look for the different ways. Now, typically, we are thinking of canine rise. We know they're going to go sideways. We like to use that canine to disclude the teeth in that movement. So let's assume that the patient moves sideways on a deprogrammer. That's a kiss of death, a canine contact. Suddenly, the deprogrammer worked for 2 or 3 nights, and then their joint started to hurt. Oh, you passed the 2-day barrier. No, it's because the parafunction goes, oh yeah, there, I'll just do this now. That's what happens. So now you've got the translated condyle on this side with a canine contact on the same side. That is really bizarre to do, to bring your condyle way far forward and then to clench like crazy. It doesn't happen in mastication. It's a parafunctional act that can be really damaging. Suddenly, you didn't want to mess around with the NTI therapeutic protocol. You got a panky device, it costs you 25 cents, and it goes. 2, 3 days later, they're miserable, and you go, oh, those NTIs suck. It's a protocol, it's not a piece of plastic. This is all about the protocol of what this parafunctional activity is capable of and how to disarm it. It's almost like it's anchored. As soon as a canine hits a contact, or as soon as 2 molars touch it, boom, everything stops. It's anchored, it's in lockdown, it'll squeeze right there. So you modify the deprogrammer. So as you modify that, we call it an enhanced deprogrammer. We like that term, to play keep away from the canine. And that's the device that I started using for a long, long time. Why? Because when I was in dental school, we made splints on the maxilla. So I started making these things on the maxilla. And then all of a sudden, friends of mine, Mike Melker, says, well, at Marquette, we make them on the mandible. And we're Marquette, and you're not. Maybe you should consider on the mandible. No, why would I do that? Oh, by the way, how long will this last? What's great about these slides that I made 15 years ago, now plenty of studies are out. Here's in 2007. Some other guys in Scandinavia or wherever they're from, an NTI splint suppresses muscle contraction intensity indefinitely. It's not short term. We used to think that splints don't last very long. Got an intense patient, put the splint in for 2 or 3 days, weeks, they feel better, then it comes back. Oh, splints are short-lived. No, the patient just gets used to it and can squeeze on it because they can. And NTI doesn't allow it. The physiology isn't there to make it happen. So back to this where we've modified, enhanced the deprogrammer to keep away from the canine. Some patients, you give them 2 or 3 weeks, they just keep on going. I've had patients do that, and they put a canine right dead center on the upper midline, and they go like mad. And it's hard to get them to do it in the chair because their teeth are together, and they start, no, I can't. Stop it. Put their device in. Barely touch it. Go side to side. All of a sudden, their jaw goes, away it goes. It happens a few weeks after you put the device in because you start to get relaxation or less intense activity. Their range of motion is now improving. And now they can go farther than they could before, so they do. And as soon as that canine hits a contact, boom, lockdown, and they start to squeeze there. Same jaw position. Put the device on the mandible. Now you're playing keep away from the upper canine. Doesn't matter. It's still incisal edge contact. So my default device now is on the mandible. Well, yeah, but we all know that NTIs and point stops, they distalize the condyle. Hear stuff like that all the time. That's another TMD Vinci code. The reason why we think anterior midpoint stop devices, quote, distalize the condyle, because we've been staring at our articulator since the first day of dental school. It's all gravity-based. Articulators clench all night long, every one of them. And if you went to Southern Cal where I went, where it's hot in the summertime, you do a full arch wax up, you never let those teeth touch the lower model at nighttime. You've got that incisal guide pin because it'll just melts, it gets so hot. So you drop the incisal guide pin, drop it down, boop, boop, and all of a sudden the condyle seems to be going distal into the fossa. If you could just make the articulator the way it's supposed to be, with the maxilla stable, muscles of elevation only have their unique orientation. Their design is always superior anterior. There isn't any other way for that condyle to go than superior anterior. Doesn't matter what happens out here. The force vectors are always the same. Now, if you had an NTI device that was really weird, and the patient bit down, it hurts their incisors, they will come back the next morning. If you didn't pay attention, they'll come back and their teeth are super sore because you didn't get it right. You didn't get the plastic perpendicular to the incisal edge. So I flip this thing around. Let's take this here and flip it upside down as if you had an upper NTI device. And this is a lower incisor contacting a discluding element. We want to know, why do we think that that would distalize a condyle? Here's Jeff Okeson's textbook on how to make a flat plane splint. First thing you do, you make a flat plane and you can add a little bump here in the front. And he says, don't forget, the functional pull of the major elevator muscles will seat the condyles in their most superior anterior position. That's because the force vector is superior anterior. That's why it does it. There isn't anywhere else it's going to go. He said, but look out, if you make this thing angled, there'll be a distal incline. It'll deflect the mandible posteriorly. This isn't gravity-based like on an articulator. This is a real mandible. There is no way to deflect a mandible distally. Now, if you're making this in the chair and this thing is angled, the patient bites down, they go, that's weird, and they'll pull their jaw backwards. As they bite and squeeze, they go, it hurts. Oh no, I'm distalizing the condyle. Well, they're responding to the strain of their incisor. So these force vectors, you don't get to change those force vectors. Those are always anterior superior. That's where that condyle is going. Here's another example. If you change it the wrong way, you'll deflect the mandible anterior. It's not possible. You'll deflect the incisor anterior, you'll push it forward, the tooth will hurt. That's not going anywhere. So we come back and take a look at this. Well, how can we help this guy for these final two conditions? Let's put an anterior midline incisal stop here. And by doing so, you now suppress the clenching intensity down to about 30%. The guy's not going off the map anymore. As he moves excursively, now you've avoided that canine. So that particular patient, that worked great for him. And he goes, I came to you because I needed an NTI. I go, no, you don't. I put a bump on your splint and you haven't done anything weird since then. You're fine. I don't care what this looks like. My goal was to minimize muscle contraction intensity and minimize joint strain and load. Those are the only two rules of parafunctional control. All right, how can you screw it up? You got to be able to screw it up. That's what the course is all about. I'd much rather have you not do anything or do it right and not screw it up. How do you screw it up? So let's say you've made this lower NTI device. The number one error is excessive vertical dimension of occlusion. Too much vertical. There's the two rules. You're taking a look at this thing and you go, you know what? I see a palatal cusp and a distal buccal cusp. They're really close in there. And I know you're going to go side to side and they're going to get really, really close. I need to get them farther apart. Because that bugs me. I expect this condition to find that and to make me look bad. So, well, I don't like to, sometimes I will never touch a tooth. I can treat a patient while never adjusting a tooth. I will just increase the vertical a little bit right here, and sure enough, bite really hard, and I didn't increase vertical too much because they're squeezing, it doesn't hurt them. Awesome. Well, give the parafunction a couple of nights to figure out how to make you look bad. So what if you didn't notice that you made this nice and parallel, because that's the way we always like to make things, parallel to an occlusal plane, and this patient decides to protrude on you. Now you've got excessive vertical dimension, excessive condylar rotation in protrusion. On the device you just thought you nailed by avoiding that posterior contact, and they bit on it really, really hard, load test, worked great. Now they feel worse. You go, I don't know, man, these NTIs are just kind of weird. I don't like them. That's what you got to do. You have to reduce the vertical dimension, and you got to slope the distal side of that discluding element from there to there. And when I'll see a patient that has got an NTI device and it's not helping them, they come to see me, tell me what your problem is, blah, blah, put it in, go forward as far as you can, and squeeze. I go, I get after that thing. I will reduce that way down, and it's a night and day difference to them. So now you've acknowledged that problem. And now the patient goes back into their retruded clench and they go, oh, darn it. Those things are super close. And sure enough, they move excursively and you can see the tip of the distal buccal cusp and the tip of the palatal cusp, they sort of touch each other. And you can extrapolate. If they're barely glancing each other during the day, they'll hit them at night and squeeze like crazy. And that is when I do my occlusal adjusting. If they can wear an NTI device and find a posterior contact, that football diamond comes out of my hole. Boom! I don't mess around. I'm sorry to say, Dr. Melkers, if you're out there, I don't take models. I don't mount them. I don't get out my blue paper and tap, tap, tap. If they can have that thing in their mouth and have a posterior contact, I've never met a palatal cusp that I didn't like. I hate them all. Death to palatal cusps. So that's what I do, even though I showed the distal buccal. So this patient had a device made in San Diego by a great practitioner who was really onto it. And that's how the patient presents. And I'm already thinking, well, I know this. That guy is going to be a protrusive clincher because he's got a lot of force generated already on those incisors. There's no place else to go but forward. I'll bet you that's what that guy does. So this device was made for him, and that little extension was made so he couldn't retrude. He thought there must be an airway problem going on. And the patient would bite on that platform. They bite right here into this platform. So I asked the patient, okay, make your chin go as far forward as you can. So that's what he could do. I put that device back in. He went right out in front of it, way out there. The practitioner didn't think he could do it, didn't even look for it. But I have to assume the weirdest things that you could possibly do. So there's a pencil line right there. That's to show me where my new acrylic starts from. So I put a pencil line on the original device. I can add clear to see where I was. So I'm now making this little platform out here. And so now when he protrudes, he still has his incisal contact. That seems like a lot of vertical opening to me. And I would have been willing to hack into this thing completely, but it was somebody else's device that kind of gave me the creeps. You do not want to mess with other people's real estate like that. I'll add to it. I put the pencil line there so I know where I can take it off. If he protruded and squeezed, I went, that hurts. I said, look, right now I need to considerably shave this thing down and ramp this kind of thing up, but I don't want to do that. Fortunately, I didn't have that problem. That is from 1989. That is a Boyd discluder. So in San Diego, I was making that for me and lots and lots of patients. So when I was third year dental school, my roommate and I drove down to San Diego from Los Angeles. We went to USC to watch a Terry Tanaka lecture. And the thing I remembered, and it hit me, I was 3 years into practice when I remember him saying, when the patient is in acute muscular distress, and you've got a full coverage splint, put an anterior midline point stop on your splint. Now, Dr. Tanaka is affiliated for USC, so it's a maxillary splint. An anterior midline point stop on the maxillary splint. Get your patient out of pain. And a few days later, take the bump off. So I was a miserable human being. I had a headache every day for 12 years in a row. I woke up with a headache. I went to bed with a headache. I took 13 Excedrin a day. It started when I was a sophomore in high school and I was 2 years out of dental school. So I was miserable, and I was a TMD resident at USC and learned all about trigger point injections, all that kind of stuff. Nothing helped me. I was down to wearing my splint 1 day in, 2 days out, 3 days in, 1 day out. I had to play catch up, cat and mouse with myself. So okay, that does it. I put an anterior midline point stop on my maxillary splint. For 3 or 4 nights, it was just awesome. I couldn't believe it. And then, so I made that. Worked great. Shortly thereafter, I started getting symptomatic again. Darn it. I got way more than the time allotted, but now I'm hurting again. I found out I was sitting there grinding on something in my office, and I was like, I had this weird face. Like I was doing a Bruce Springsteen concert. What am I doing? I had my little excluder. Oh, yeah, I bit right in front of it. I don't bite like this anymore. I bite like this because that's what I need to do to mess with myself. So I needed to make that discluding element come out this way because I'm going to protrude. I thought, all these patients, I couldn't figure it out. They were having a stiff sore neck. Oh, no. That's how the NTI design started to grow, because my insight to parafunction truly was insight, because I was experiencing and I started monkeying around with my own devices. This was presented in France several years ago now. Of 90,000 NTI devices provided and observed, 1.6% there was a claimed undesired clinical change in the occluding scheme. Doesn't sound like very much. How many flat plane, cuspid rise, custom-made splints were made in the last month in the United States? 100,000, a couple 100,000? Maybe 1 or 2% they had problems. What manufacturer is responsible? Nobody. These are all individually made. There isn't any requirement for any logging of any complaint. But 1.6% of 90,000 devices, there's 1,400 complaints. So now, where do these people go to? They go to the TMJ specialist. Something weird happened, and oh, these things are awful. No one cares about the other 98% of successes, because this is a manufactured product by a company with FDA clearance, and so there's a little bit of weirdness about this because it's now public as opposed to the splints that we all make and no one ever hears about. For some reason, when this person bit down, these teeth fit okay into this bumpy little anterior plane that they had. So this is the NTI device that I made for her. I use a thermoplastic material, and we'll go through a little protocol of that in a second. As she bit down, I was concerned that there'd be too much vertical dimension, but I have her squeeze as hard as she can. It didn't bother her. I had her protrude, and she moved off to the side, hit one tooth. That felt weird, and it sort of felt weird around her cheekbones. Whoa, too much vertical on that one. That's with the discludium ramped down. Here's a side view of that. She had this big goofy thing when she came in, and this is the lower NTI device that I made, and she does fine with it, but I have to make sure she does all of the extreme excursions to see what's going to happen to her tonight.
Do you not trim that thermoplastic back?
No. I love, who said that? Do not trim that thermoplastic back. I love that stuff, and I used to have to because I would put too much in there. I hadn't done enough of them. Now I get it. It's like when the chef goes, oh, just take a pinch. Come on, how much do you really use? So it's about a teaspoon now I put into the boiled water. That's about the right amount. And if there's more than I need, I let that stuff go around the horn a little bit. I would much rather massage it and leave the excess and have ideal retention than to worry about cutting the thing back. Now, if the patient goes, oh, my friend's device doesn't look like, my friend's is really pretty and really clear. Well, I'll show you what an NTI Plus looks like. Those are cool. Mine are big, goofy looking marshmallows, but they work great. But I'm a hands-on guy. I'm the other send-on guy. Everything happened on this one patient. He's got left joint pain, his joint's up there. Left joint pain, he's had lavage done in his joint. He's had failed splints. He's had a root canal done on number 18 twice, because that tooth is killing him. He's got left sinus pressure, chronic headache, stiff and sore neck, and frequent migraine. I said, well, you might need an NTI device. I bet you're clenching on number 18. He goes, you mean like the one I'm about to show you, this NTI device? Yeah. So first of all, make your jaw go over to the left. I bet you're clenching on number 18, and sure enough, he could do it. He'd squeeze on tooth number 18. Now, that is a contraction of the left lateral pterygoid, and now it's resisted. It's sort of like opening your mouth and pushing really, really hard, and you start to feel it into your sinus. I think that guy would go excursive, lock up on those molars, and squeeze like crazy. He pulls an NTI device out of his pocket and puts it in, and that device will relieve that point of resistance, and sometimes without the anchor, the mandible can go a little bit further. So when he put this device in, his jaw moved even more. He still had a place to contact. So that's why that's now at 19. His tooth felt different. He's got a different kind of a toothache, still has the sinus pain, still has the headache, still has the migraine. Because we still have the problem. Out comes my football diamond, and I'm going to relieve that point of resistance. And when I do that, he moved over even farther. But that didn't hurt him. He no longer had the ability to generate maximum clenching intensity in an excursive position. Fortunately, the vertical dimension wasn't a problem here. If it had, I'd start all over. But I like to take what the guy's got in his pocket and whittle on it or do a tooth and be a hero. My point is, the patient is a different patient every time you see him. Because if you've got a device going like this that's going to modify their ability, that means their ability is different. They're a different patient. You have to ask them to do things that they may not have been able to do before. He wants to know, when a patient's clenching in a centered position, are you kind of focused or worried about having both centrals, both incisors hitting simultaneously? Yes. And I don't have a slide. I'm so glad you asked that. We knock ourselves out to get perfect occluding on the splint. We've got the blue paper and the whole business to get it balanced. Now we're even thinking, well, an NTI, don't you want balanced? You got the two centrals. Sometimes one central's taller than the other. Sometimes it's, oh, great, I'll put it on the upper teeth instead, and now the lowers are jumbled all over the place. You can't get a nice balanced occluding scheme on an NTI. One central hurts more than the other. Why have I been so worried about that? I now make a, quote, slider on everybody. A slider is an NTI device without a discluding element and very, very thin occlusal coverage. So what I've created is a slippery plastic surface along the 8 and 9 edges, or 7, 8, 9, 10. Flat and slippery. A lower discluding element, boom, touches, they slide all over the place. So I actually put it both in at the same time and have them bite down. It's like, it's cheating. I don't have to be a dentist. I have to look about occluding schemes. That's great. Thanks for asking that. So here are the principles of parafunctional control. We want minimal muscle contraction intensity. In normal mastication, you don't get beyond 30% anyway. No one really needs to go to 100%. If you do, it's for a short burst of time. We accomplish that by having incisal edge contact only with minimal dynamic resistance, and that's where that slider comes into. If they move sideways, the teeth are irregular, they can also lock up and have resistance to movement. I want no resistance to moving. I want minimal condylar rotation during excursions and protrusions. I'm assuming there's occluding going on. So when there's occluding going on, I want minimal condylar rotation. I do that by minimizing the vertical dimension of occlusion of the discluding element in all excursions. So those are two things you got to remember. Some would say, well, before I would ever make an NTI, of course I would do load testing. I like to load test the joint. So I can they'll use an anterior jig or something like that. So a Pankey device, an anterior jig on some patients, if you put it in there and have them squeeze on it, it hurts them. Whoa, couldn't use an NTI patient on this one. Load testing failed. How about, and there's a Pankey jig, too big in this particular patient. How about making this much, much smaller and let them close into a normal, closer incisal edge condition, and that won't hurt them. If it's too big, it hurts. Here's a teaspoon of those thermoplastic beads. When you put them in boiled water, they will coalesce as they turn clear. You can fish them out with a spatula, or I'll just reach in with my gloved finger. However, when you do that, you have to use latex gloves. If you use the nitrile gloves, this thermoplastic nitrile instantly, permanently bond to each other. It's hysterical. So I've been to another office. Oh, can you come to our office and treat? Sure, I'll come over. Ta-da, I'm here, and give me some gloves. I'm making an NTI for this patient. They put this happened to me, but reach in there like, I couldn't do it. So latex. So now you take this blob There's a lower NTI device, and I like to pre-sculpt this in advance. I used to put the acrylic in, let the acrylic cure, and sculpt the whole thing. Now I do it differently. I will put it in the patient's mouth, look around, and I will reduce the thickness here, and I'll pre-sculpt it and put the thermoplastic inside it. And that, to me, although it looks like, wow, there's a lot of extra, there probably is more. I don't use that much anymore. Patient doesn't know. It doesn't bother them at all. There's an excursive movement. Make sure that if you put too much of a blob back here, suddenly that canine will touch something that was never there before. You create a new occluding scheme. So I have to look for stuff like that. And look how far over this person can go. They never had to do this before. They've never had a device that would allow that much movement. The lower canine's right there. And if you had made an upper NTI device, they'd be right on top of that thing. Good thing I made a lower on that one. Here's that patient I showed before in protrusive. I grind down that discluding element to get minimal extrusion. Here's this NTI device. I would make him with snap acrylic from Parkel. I think Parkel might have changed their formulation, because the nasty thing about NTIs for a long time, when I was using snap acrylic, clear, colorless, incisal, snap composite or acrylic resin to make temporary crowns, it turned a weird looking yellow after a while, like cigar yellow. That doesn't seem to be doing that anymore. However, I think the monomer or the change in the formulation is even more attacking to the lexan of the NTI shell. I haven't used acrylic to line an NTI device in 6 or 7 years. I always use a thermoplastic. I love that stuff. Migraine happens typically first thing in the morning for 71% of sufferers. They have headache in the morning. Now take a look at this study from The Lancet. 62 consecutive subjects that have chronic headache, ruled out all the dental problems, had it most of their lives. I've seen plenty of doctors already. Could be bilateral, sometimes unilateral. And they'll usually wake with a degree of headache. I recognize that patient. They made an anterior bite plane. After 6 weeks, 2/3 of them had resolution. What's really crazy about this, and at 3.5 years, they still were okay. Didn't know, it was in 1960. It was a long time ago. Why isn't anything done with it? Because that's not a manufactured device. You have to publish a bunch of studies and convince dentists to do it. And in 1960, that wasn't on the radar. At our neurology clinic, we presented this in Berlin, I think, but 20 consecutive chronic daily headache patients. Chronic daily headache is a medical diagnosis. They've got migraine at least 12 days a month. They've got a headache every day. These are the worst of the worst patients. You can't do anything with them. And so those are the patients that we worked with. And it was the same consideration, the same components of this prior study. We make an NTI device, and we use what's called the headache impact test, or the HIT6. There's 6 questions. How badly does the headache impact your life? And so 9 patients had no impact, 5 patients some impact. That's a fantastic result for this group of patients to have that sort of resolution. What was most important, though, in the neurology clinic wasn't these successes. I told Dr. Blumenfeld, I think it's going to work on everybody, because my family says I think everybody clenches and NTIs just help everyone. So that's what's going to happen. Sure enough, it didn't. They all seemed like the same, but when I could present a patient that fits this criteria and an NTI doesn't help them at all, that's a fantastic rule out for the neurologist. Those guys just light up. So in in the neurology clinic I associate with, there's like 7 guys in there. There's 4 of their wives were NTIs, their daughter, all the whole thing. If they go, that didn't help that patient, and I've had one patient had an elevated cerebral spinal fluid pressure, because as they thought about what could it be? They could find these more weird things. And neurologists love to find weird things. That's what they're supposed to do. So I could rule out for them usual and customary. Here's the questions that I asked these patients. This is the patient with no wear on their teeth and no joint pain. On a scale of 0 to 10, 10 being the worst pain imaginable above the shoulders, how many mornings per week do you wake with a 0? You feel fabulous. You can't say, do you wake up with headaches? Because they'll say no. Their perception of normal is skewed. A 4 or 5 level headache is tolerable and medicatable, and they go about their life. A 6 or 7 or 8 might be medicatable. 0 doesn't compute to them. You have to call that fabulous for them to go, no, fabulous. Okay, once, maybe twice a week I might wake with maybe, I don't know. Then you say, okay, 5 days a week you wake up with a number. Yeah, okay, you got that far. On the mornings that you wake up with a number, what's the average number that you have? I don't know, 4, 5 or 6. Almost every day you wake up with 5 or 6. Yep, that's the average. You ever wake up with like 7 or 8 or so on 9? They go, yeah. Terrible, isn't it? Yeah. Does it freak you out? No. You wake up with a 1. Does that freak you out? 2 days in a row? Yeah. Totally unfamiliar to them. They don't get that at all. Normal is a degree of pain, so they have skewed their thing. If you ask the wife, hey, you want to go to lunch? Okay. You look pretty good. You got your eyeshadow on. You're looking pretty good. How do you feel? Do you have a headache today? Yeah. Oh, I'm sorry. Did you want to stay home? You know, if I told you when I have a headache, we'd never go anywhere. Why do you think I have the eyeshadow on? So I can look better. I feel terrible. That happens all the time. This graph represents these 20 patients. The blue bar is the number, 7, is the number of days per week they would wake up with a headache. These guys, every day they wake up with a headache, 6 days a week a headache. The number of days they wake up with a headache. The yellow bar is the number of days they wake without a headache after treatment. That's one of the things I tend to follow with these patients. And these people that had no change at all, those are the ones the neurologists want to know about. I couldn't rule out clenching for them. I am a chairside, make stuff with my own hands kind of guy. Keller Lab makes these NTI Plus. These are, what's the name of the material that they're made out of? Crystal clear?
Crystal clear.
These are not therapeutic devices. They get you out of having to do what I do and how much putty do you do if it's too much, all that kind of stuff. These look terrific. They're not going to turn yellow, but there's one thing they can't do is treat the patient. We do that. When I look at these things, I start thinking, is that too much vertical at the back end of that lower discluding element? Does this need to be ramped down a little bit? This is an upper version. Does that discluding element need to ramp up? Because so when they protrude, they're not opening still further. Upper NTI devices, typically the discluding element is ramped down because they like the discluding element up back behind the incisors, which means that it's ramping down. So the patient protrudes and they're opening more condyle rotation as they protrude. So an upper NTI device that is beyond the incisor, it's got to get back to level and ramp itself back up. So I've had dentists actually say, I don't know about those NTI pluses. Sometimes I have to grind on them. Huh. You better look. You better look and see what's going to happen. I mean, you grind on it and you polish it. Big deal. Otherwise, you think the NTI pluses don't work. Because it's a therapeutic protocol. It's not a piece of plastic. I love that thing. They call that the Terminator. I can remember making an NTI device and they would just shred that discluding element. Shred it. I would take an old 557 burr, instead of throw it away, I would dig a trench in the discluding, bury it in there with acrylic. So there are patients with no posterior occlusion generate enough vigor to shred anything anteriorly. They don't have any symptoms, they're just blasting through devices. You can have metal on metal. Once you get what's happening to these patients, how it gets that way and how it stays that way, it's all arts and crafts after that. This is a perfectly legitimate, smart thing to do. So how would you treat these different versions of bruxism? For the grinding patient that has no symptoms and their teeth are worn, you can wear just night guard, whatever you want to call a night guard that covers their teeth. If they don't become symptomatic, that's fine with me. If they have excursive clenching, and that's the TMJ patient, joint strain, dislocated disc, you have an occlusal splint or occlusal therapy that's pretty precise. The absence of posterior contact and excursive movements. Canine rise with quick transition over to incisal guidance without going to canine contact. You can do that in splint, you can do that with the teeth. But that is really an attention to detail thing there. I wouldn't just take a night guard and throw it in there. Sometimes it helps. For the primary clenching patient, that's the anti-therapeutic protocol is perfect for them. Now, if you take a night guard and put it into a TMJ joint pain patient, sometimes it helps them. Sometimes it doesn't if you don't know what you're doing, but if it doesn't help them, you're like, whatever. But you would not take a traditional, regular old night guard and put it into a primary clenching migraine patient. You'll probably just make them worse and they'll just give you a bad name. You don't want to do that. But fortunately, no one seems to know what's going on anyway. No one's making a full coverage splint for a primary clenching headache patient because we didn't know they were existing. Now, would you make an NTI for the TMJ patient? You bet. Great way to reduce strain and load on a deranged disc. What do you want on a deranged disc? Minimal joint strain and minimal load. How do you get it? You get strain and load. First, you have to have increased muscle contraction intensity. Then you have to have the force vector to pull sideways. So you don't let there be posterior contact and you don't let excessive rotation. Great thing to do. Would you make an NTI on the guided grind? No, don't do that because I have to hear about it, not you guys. So this patient doesn't have any symptoms. Oh man, you're trying to convince him to wear a splint to protect your porcelain, and he won't do it. How about, my wife's got one of those little things. Why can't I just have one of those? Oh yeah, your wife had those headaches and she loves her NTI. Now this guy wants me to make him an NTI. He doesn't have symptoms. He's worn his teeth flat and they're edge to edge. I'm going to make him an NTI. He's going to get muscle normalization. His condyle is going to seat more superiorly, pivoting off the posterior molars, separating his incisors and CO. He's going to get a little bit of anterior open bite. He's going to beat the crap out of me. Don't do it. You don't need to. If someone doesn't have any symptoms, you don't need to be making them an NTI device. If they're raging, grinding their teeth, and you talk to them and you know that they've got considerable overlap great. But this is a therapeutic protocol that is quite powerful in helping people when you know what you're doing. You could also mess with someone if you're not really aware of what's going to happen to you. So the when and why of an NTI, here's when. Here's when not to, when you don't need to. That's my show, ladies and gentlemen. If you email me, I will email you right back.
Chronic migraine sufferers are keeping a secret. They can't hide those times when they're having a migraine attack. But what of the rest of the time? Don't ask a migraine sufferer if they have a headache when they wake up, because they'll say no, and that's not the real answer. Instead, ask how often they wake with no pain at all. That is, they feel fabulous. And they'll hesitate. Keep digging, and you'll find they constantly wake with a low-grade to moderate headache as their norm, but simply don't rise to the level of demanding a change in their activity. They've just been forced to live with it. And they dare not complain to their physician for fear of being accused of the rebound effect of overuse of their medications. The truth is, chronic migraine sufferers have a degree of a headache most of the time. They just keep it to themselves for fear of not being taken seriously during their severe migraine attacks. Migraine is a disorder of the trigeminal sensory nerve. But despite the common episodes of disabling pain shared by sufferers, There is no known common identifiable pathology amongst them. However, there is one common trait: a hyperactivity of the trigeminal motor nerve that causes intense nocturnal jaw clenching, resulting in the average migraine sufferer having developed the ability to clench their jaw with twice the intensity and force of normal. Managing nocturnal clenching of the chronic migraine sufferer is like eliminating daily candy bars from a diabetic. You don't cure the disease, but can dramatically reduce disability and improve the quality of the sufferer's life. The challenge has been how to minimize nocturnal clenching intensity. The traditional dental mouthpiece provides a surface for the migraine sufferer to clench on, thereby allowing intensity to increase and making symptoms worse. A new mouthpiece design, called the Nociceptive Trigeminal Inhibition Device, or NTI, has recently been approved by the FDA for the reduction of chronic migraine disability via minimization of jaw clenching intensity. Its simple design exploits the protective nature of natural incisal biting, that is, biting with the front teeth, which governs the intensity of clenching to 30%. In blinded crossover studies comparing to placebo, the NTI produced a significant to profound reduction in disability of chronic migraine sufferers. Moreover, being drug-free, the NTI is safe to use for women in childbearing years. So, if you or someone you know is a migraine sufferer who wakes with a degree of headache as part of their normal, have them visit migraineprevention.com.
Here's the questions that I ask these patients. This is the patient with no wear on their teeth and no joint pain. On a scale of 0 to 10, 10 being the worst pain imaginable above the shoulders, how many mornings per week do you wake with a 0, you feel fabulous? You can't say, do you wake up with headaches? Because they'll say no. Their perception of normal is skewed. A 4 or 5 level headache is tolerable and medicatable, and they go about their life. A 6 or 7 or 8 might be medicatable. 0 doesn't compute to them. You have to call that fabulous for them to go, no, fabulous. Okay, once, maybe twice a week, I might wake with maybe, I don't know. Then you say, okay, 5 days a week you wake up with a number. Yeah, okay, you got that far. On the mornings that you wake up with a number, what's the average number that you have? I don't know, 4, 5 or 6. Almost every day you wake up with 5 or 6. Yep, that's the average. You ever wake up with like 7 or 8 or so on 9? They go, yeah. Terrible, isn't it? Yeah. Does it freak you out? No. You wake up with a 1. Does that freak you out? 2 days in a row? Yeah. Totally unfamiliar to them. They don't get that at all. Normal is a degree of pain, so they have skewed their thing. If you ask the wife, hey, you want to go to lunch? Okay. You look pretty good. You got your eyeshadow on. You're looking pretty good. How do you feel? Do you have a headache today? Yeah. Oh, I'm sorry. Did you want to stay home? You know, if I told you when I have a headache, we'd never go anywhere. Why do you think I have the eyeshadow on? So I can look better. I feel terrible. That happens all the time. This graph represents these 20 patients. The blue bar is the number, 7 is the number of days per week they would wake up with a headache. These guys, every day they wake up with a headache, 6 days a week a headache. The number of days they wake up with a headache. The yellow bar is the number of days they wake without a headache after treatment. That's one of the things I tend to follow with these patients. And these people that had no change at all, those are the ones the neurologists want to know about. I couldn't rule out clenching for them.
When I say go, I want you to bite on your back teeth and clench your back teeth together. Go. Clench, 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 relax. That's better. Okay. Yeah, but you have the anti in now? Want to put it in now for me? When I say go, I want you to start to clench. Go. Clench, clench, relax. Go. Clench, clench, relax. Look what happens to the ability to clench.